Are you one of the many frustrated individuals that's put their trust in SIBO breath testing only to be left without benefit from the results? Breath testing is considered the preferred test for SIBO, but ironically lacks the validity to be considered a go-to test. It's starting to appear that testing aimed at digestive ability and motility might be more useful. Let's make you aware of this approach. Small intestinal bacterial overgrowth is often looked at as an overgrowth problem. In reality, the overgrowth is a byproduct of impaired digestive secretion and slow motility and is characterized by nutrient deficiencies. If the overgrowth is secondary to the changes in the gastrointestinal function, why aren't we using tests aimed at the challenges to the gastrointestinal function instead of those directed towards overgrowth? Let's look at how to use this information to diagnose SIBO without breath testing. But before I do, allow me to introduce myself. I'm Dr. Arland Hill, and for over 20 years, I've been helping first-time and recurrent SIBO sufferers restore their gut function by targeting all three phases of the condition to resolve symptoms in a timely manner. Allow me to start off today by reiterating a fact that is extremely core to today's content. Yes, SIBO is noted as an overgrowth, but SIBO is a condition of poor digestive secretions and slow bowel motility, and it is characterized by nutrient deficiencies. The overgrowth, it's secondary. So why don't we use tests that reflect what the dysfunction in the gastrointestinal tract is? Not the focus on the overgrowth, but the focus on the impaired digestive secretions and the slower motility. Breath testing focuses on overgrowth. So let's look at a different strategy here when it comes to diagnosing SIBO. I also want to start us off by noting that with any clinical condition, the most important thing when it comes to that diagnosis are symptoms. What does the history look like? The basics. The fundamentals is what we're talking about here. So in the case of SIBO, for symptoms, looking at things like gas, bloating, painful distension in the abdominal area, constipation and or diarrhea, weight loss, which is going to be secondary to malabsorption. Those are the symptoms that we're looking for. If you check the box for most of those symptoms, you're already in the SIBO channel irrespective of any testing. Well, what about history? Well, if you have a history of antacid use, or you've used some different pain medications that are going to slow down your bowel motility, you've used antibiotics, you have something like a Parkinson's presentation, or you've had gastric surgeries, or you have diabetes or hypothyroid. These are all things that the more of these that you check off on, the greater the probability that you have SIBO, and we haven't even talked about doing testing yet. So I want to just simply emphasize that symptomatology and history make a big difference in this conversation. But that doesn't mean that testing is not beneficial. Testing is absolutely beneficial. But what I'm going to do is introduce an option for you that is typically not considered to be an option for SIBO. And the reason that that is the case is because the focus in using that test is on the overgrowth. But remember, we're not looking at the overgrowth here. We're interested in the dysfunction that set the overgrowth up. Stool testing can tell us that. Stool testing can help by giving us information about those digestive secretions. So we're not using it for the overgrowth, we're using it for the feedback that it gives us about the digestive secretions. So we want to think outside of the box in terms of how we use this information. When you look at SIBO, the digestive secretions that are impaired here are there can be a combination of these. We could be looking at an impairment in acid production. We could be looking at how that affects the pancreas directly, or if there's a problem with the pancreas in and of itself. We could be looking at the bile secretion from the gallbladder. all of these are going to impair the ability to kill off of these organisms that are going through your small intestine if they're not being produced in sufficient quantity. So with that in mind, the first thing that I want to introduce to you here that you could find on a stool test is what's known as elastase 1. When you have the inability to secrete the enzymes from the pancreas, this goes by the name of pancreatic exocrine insufficiency. It's a bit of a mouthful, but ultimately what it means is that the pancreas is not secreting enzymes efficiently. Well, elastase 1 can give us that information. It can tell us if the pancreas is working at an optimal level and secreting the level of enzymes that we want to be able to inhibit the growth of these organisms that are moving through the small intestine. And the nice thing about this is that this also ties into not just what treatment to select, but also gives us insight into how aggressive to be with that treatment. If it's just appears to be a slight drop in elastase 1, then we maybe don't need to be as aggressive. However, if we see that there's a significant drop, maybe we need to be more aggressive in trying to meet that metabolic need for digestive enzyme support. Because this is not just going to be part of what reduces the number of bacteria that are going through the small intestine and inhibiting an overgrowth. This is also going to directly play a role in digestion as well, and making sure that your food, after it's been chewed thoroughly, is getting broken down chemically with the acid and the enzymes and the bile in the small intestine. So elastase is, again, something we can see on the stool test, but it's not by itself. We also can see a marker known as steatocrit. And steatocrit can give us insight into fat malabsorption. But steatocrit is a reflection of what the bile acid production is. So if someone is seeing excess fat in their stool, which is what steatocrit would reflect, that would be an indication that some bile support may be necessary for that individual. Interestingly enough, a reduction in bile is also going to have an impact on motility. Remember, motility is another aspect of this. Bile acids are one of the components that naturally influence the motility. They're a natural, just to use the word laxative here, but they support the natural laxation process in the bowels. So they're just part of the normal motility, if you will. Without those bile acids, you're losing that motility support. You're losing the antimicrobial support. So you're not killing off those bacteria, and you're not supporting adequate fat digestion, which is going to indicate ultimately the malabsorption of things like vitamin A, vitamin D, vitamin E, vitamin K, as well as the different fats that are coming through your diet. And remember, nutrient deficiencies are a characterization of SIBO. And I'm going to speak more to that and how you can use that information as well. But that's two of the three digestive secretions. So the one that I didn't mention here is acid. Now, you're not going to get a direct assessment for hydrochloric acid production in the stomach by utilizing a stool test. You're not going to see that. But that doesn't mean that we don't have insight towards that. And there's two things that could possibly show up on a stool test that could give you this insight. So the first is going to be that when you have a drop in those pancreatic enzymes, remember that's indicated by elastase 1, that drop in pancreatic enzymes may also be reflective of an inability to secrete adequate amounts of acid. And the reason that that's the case is that we need acid secretion in the stomach in sufficient quantities to ultimately trigger the release of enzymes from the pancreas. So that low pancreatic enzyme production may reflect a need for acid as well. But there's a second way on this stool test that we may get some insight about what the acid production status is also, and that is by looking for H. pylori, also known as Helicobacter pylori. This bacteria, which can be residual in the stomach, that I will note shows up in half of the population, can also damage the cells in the stomach that are responsible for acid production. And it is well established that there is a link between H. pylori and SIBO. And worth noting also here is that H. pylori also creates nutrient deficiencies. So the way that you tie all this together is that if you see H. pylori, it raises the suspicion that that may be a culprit in acid production. It raises the suspicion for SIBO. And so now when you look at the stool test, not as directly a measure of the microbial growth, but as an indicator of gastrointestinal function, of which you know is directly aligned, that dysfunction is directly aligned to the presence of SIBO, the stool test becomes a very important ally in managing SIBO, especially when you're looking at trying to prevent recurrence, which is ultimately what you should be working towards anyway. Eliminating the overgrowth, that's just the starting point. We have so much more to do to rebuild the physiology, and stool testing gives you insight into rebuilding physiology that a breath test is not going to do. So right there, you can see that breath testing for SIBO, especially when you combine it with a good history and with symptom matchup, is not going to be necessary. But there's another test that I think should be considered in here as well, and that is nutrient testing. I just mentioned the various nutrient deficiencies that are associated with, or that nutrient deficiencies are a characterization and are associated with SIBO. And to be specific here, we're looking at things like B vitamins. I mentioned the A, D, E, and K as fat soluble. You're also going to see zinc, selenium, iron. Those are commonly deficient. Protein, that's a macronutrient versus a micronutrient. That is commonly deficient. But with the micronutrient testing, many times we can see the amino acid levels. And if those amino acid levels are dropping off, that is an indication that we may be looking at a nutrient deficiencies characteristic of SIBO as well. So nutrient testing becomes another ally that could, and in my opinion, should be used adjunctively at the same time as the stool test. So it's really about the collection of symptoms plus the lab findings is what you're using to generate this, to generate a strategy against SIBO and to diagnose that with. But there's also another strategy in here that is very commonly used as well. And this is called empirical applications of antibiotics or antimicrobials. So what does that mean? Well, an empirical trial is simply telling you that you have a suspicion about what is going on. The practitioner has a suspicion about what's going on, and they make a recommendation, they make a recommendation for what they suspect is going on. So they suspect SIBO, they make a recommendation for an antibiotic or an antimicrobial. And if the patient responds positively to that, then that was a positive diagnosis. There was no testing involved at all with that. Now, that is a very well established, and in many cases, maybe even in most cases, this is what happens with SIBO in the conventional model. And there's absolutely nothing wrong with that. I mean, if the person responds positively, then hey, winner, right? You were able to see results in a quick time frame there. The limitation on this strategy is that if you don't see results, then you've got to dig deeper and you don't have any insight beyond just what the response to the antimicrobial was. But then also it doesn't give you insight into what those digestive secretions are or what the likelihood of that individual having nutrient deficiencies that need to be corrected is either. So now that I've shared with you how to diagnose SIBO without a breath test, wouldn't you like to know a couple of do-it-yourself options for SIBO at home? Of course you would. Well, click on the video on the screen right now to see how to start implementing these for yourself right away.